we're going to get started here. Hi, everybody. Thanks for joining. This is Carol from the STS, and this is the Adult Cardiac Surgery Database User Group call for June 15th. We have quite a good show here today, so we will get rolling. And if I could just find out, on the phone with me from STS, we have Leanne Jones, Addie Dolan, Emily Conrad, Melinda, Nikki Parsons. Nikki is from our research center, and Sydney Clinton. For IQVIA, we have Jean, Joe, Melanie, and Michelle, and Steve. Thanks everybody for joining. Do some quick STS important dates and updates, and then IQVIA updates. STS education today will be on insurance. We're also going to talk about capturing devices for the various valve positions that are not currently available in the data specifications. And then Q&A. Here's a quick timeline. Today's the user group call. We have AQO, the submission for abstracts for AQO is open. That will close on July 5th. July 20th is our next user group call. We do not have a monthly webinar in July because that falls during the week of 4th of July. And I think most of us, including myself, we will be off. Next monthly webinar will be August 3rd. So user group call on the 15th, then July 20th, monthly webinar August 3rd, user group call August 17th, and that gets us to the next harvest close date, which is August 26th. That will be harvest 3, OR dates through June 30th, 2022, and it is a star rating report. Please do your best to get your data in as soon as you can, continuously getting it in, submitting it so we don't have that big rush at the end. I think last harvest worked out really nice. Folks got their data in earlier than what has happened in the past, and things flowed really nicely, and no big hiccups at the end there. So please do your best to get your data in. No changes to the harvest 2022 dates. These are posted online. And then just a couple STS updates. Harvest 2 data is in analysis or going to analysis very soon from IQVIA. The June training manual has been posted. If you need to update your contact information, add anybody, remove anybody, please email stsdb@sts.org and they can help you do that. Again, AQO abstract submission is open. And then for the audit, the notifications were sent if your site was chosen for audit. Instruction letters are coming out this week. I was told they should be coming out either today or tomorrow. So continue to look for those if you've been chosen for audit. If you were, that notification went to the primary contact at your site and the surgeon representative. And we have heard back, I think we're auditing just over 100 sites, or right around 100 sites. We have in the audit notification, there's a link to complete a survey. I believe it's a link to complete the survey. And 86 or 14 of the sites have not responded yet. So if you were chosen for audit, you received that notification, please make sure you respond back to that audit questionnaire. And the letters went out by email to the primary contact and to the surgeon rep. Check that email, complete the link in the email for the audit questionnaire and get that completed as soon as you can. 14 sites were still pending this morning on that. And I'm going to hand it over to Emily Conrad for just a quick AQO update. Emily?
Hi. All right. So we'll be in Providence, Rhode Island, October 26th through 28th. Want to go to the next slide? Okay, so I wanted to just kind of talk about some things that will be available as an in-person option in Providence. For adult cardiac, we will be having our session on Thursday, October 27th. We are not going to have a general session in person this year. That content will be on demand on our virtual platform. So I just wanted to mention that. It used to be the same day as adult cardiac, but since this database is so big, we have so much content to cover, we want to give you as much time as possible this year. So that's just something different from when we were in person in 2019. That's something we've changed in 2022. So just some things that I wanted to mention. In-person sessions, you'll have an opportunity for live Q&A. If you do, we will have a digital pass option for people who cannot be in person, but there will not be an opportunity for live Q&A if you're a digital pass attendee. So I just wanted to let you know that. We'll be able to have, and we're going to have a networking reception again with our speakers and vendors and colleagues, face-to-face time with exhibitors. We will have that virtual platform, so all on-demand content will be available on the virtual meeting platform in mid-October. That'll be, presentations that you'll be able to watch before going to AQO in person, all recorded in-person sessions, so the ones in Providence, they'll be available for additional viewing in mid-November. And then we are going to have a post-AQO webinar called Hot Topics in January. We'll bring back some of our speakers. It'll probably be a half-day event. So if there's any questions that you weren't able to get answered live, you can submit those during the webinar in January. You'll also have access to the digital conference materials such as PowerPoint slides, case scenarios, any additional materials that the speakers want to share. They'll be on the virtual meeting platform. And we'll also have CE and CEU credit available as well.
Thanks, Emily. I just want to add in that I highly recommend the in-person option for the networking. The virtual option will not have any type of engagement. It will not be a presentation, or you will not be able to see the presentations as they're happening. We're still working out the plans for when those recordings will become available to the virtual option. So please keep that in mind as you're making a decision or trying to get backing from your institution on travel for the in-person AQO. We want to try to offer the folks who are not able to join us live some type of educational option, but it will be nowhere near as interactive or engaging as the in-person option.
Correct. So. And I wanted to mention, we are going to put on the website a justification letter. It'll be drafted, and it'll have a signature from probably our like the president or maybe the council chair. I can't remember who it is, but we'll if you are like looking to go in person and you want to provide something to your supervisor or something like that, we can draft something up for you and send it to you. So that'll be on the website. I just wanted to mention that.
Great. Thanks, Emily.
And AQO registration will open next week. We do have pricing up on the website at the moment, so you can take a look at that. And if you need to bring anything forward, you can to your institution. Here's the pricing here. And then early bird registration the deadline for that will be Friday, August 26th.
Thank you.
Mm-hmm. And then I just wanted to mention that the educational sessions this year, they'll be actually in the Rhode Island Convention Center. This is the first year that we've had our conference in a convention center, so it's kind of exciting. And then the Omni Providence Hotel is connected to it, and that is where our room block is. So this information will be going up on the website soon. But I did want to mention that it's the room block is $259 if you are looking for a price for that.
Thanks, Emily. And is this link? This will take us to this hyperlink here. This go to Providence. Well, is that available on the website now?
It is. I think it says visit Providence, Rhode Island, and it's a little link where you can kind of check out the sites if you want to look into what the location has to offer.
So sts.org, meetings, live courses, and then this advances in quality and outcomes, the data managers meeting. About Providence. And then right here is where you'll find the information Emily just shared with everybody. And here, this website is really neat. This is about Providence, Rhode Island. It's a microsite that we had, I guess, built along with their Convention and Visitors Bureau. And it has just some exciting information about attractions, dining, getting to plan your visit and things like that. So I thought that was pretty neat. I don't know that I've ever seen a microsite like this for the past AQOs. Maybe I've missed it, but um, I thought that was pretty cool. So be sure to check that out in your planning. Okay, thanks, Emily.
You're welcome. And then one more
Oh,
thing to add, abstract submission. You can go to our website and you click on that button, submit abstract. Abstract submission closes on Tuesday, July 5. This is for e-posters, or if the committee thinks that one of the abstracts is would be good for an oral presentation, we might have that as well. I just wanted to mention, if you are wanting to submit an abstract, when you go to submit it, make sure that all of your authors fill out the disclosure form. The submission cannot be completed unless we have all disclosures. So I just wanted to mention that.
great. Thanks,
And
Emily.
one more thing, it's just we're in the middle of planning the program. We have another planning call tomorrow with the committee. These are some of the topics that we have discussed. We are always, interested in additional topics that you think that you might want to hear about. So if you have any questions or case scenarios or any suggestions, you can actually submit those, I believe, just to the FAQ box, and you can put that in by Friday, August 16, for your questions or case scenarios to be answered while we're at AQO. That's all I got.
Can I say thank you one more time?
Yes.
Thank you, Emily. That was a great update on AQO. Thank you. I'm going to hand it over now to Joe for the IQVIA update. Joe?
Great, thank you, Carol. Good afternoon, everyone. Just a few updates from IQVIA regarding a release that was done on the weekend of June 4th, a couple weeks ago. All in regard to the risk-adjusted dashboard report, your analyzed harvest report. STS 7815, the rating trends report now correctly displays its date ranges in reverse chronological order, meaning your most recent harvest is the first column, and then the harvest before that is the second column, and then so on. And so those dates should now be in a logical order for you. And then STS 8072, the results for the beta blocker within 24 hours calculation for among eligible cases has been updated to exclude cases where the status is either emergent or emergent salvage, and cases where beta blockers were contraindicated. And then STS 8058 on the benchmark report for isolated cabbage. Under operative information, the results for the missing line for blood products used were incorrectly including cases where intra-op blood was refused. And so it was counting those as missing by mistake, and that has now been resolved. And then SCS 8380, for the demographics benchmark report, the total number of cases was showing a dash previously, and that has been corrected and should now show you the correct case count.
Great. Thanks, Joe.
No problem.
Don't forget. Oh, go ahead.
Yeah, just the usual updates, the usual reminders that if you would like an update on your ticket or you haven't heard anything in a little bit, feel free to reach out to us and we can look into that for you. Then we will be continuing to review items that have been reported to us to bring to your attention as needed.
Thank you.
Yep.
Okay, and the support plan, nothing really has changed there. And now we're going to go into learning. On the line with us today is Nikki Parsons. Nikki is from our research center, and she's helped develop a way to collect devices that are not currently available in the current data spec, that are not available in the current data specs version 4.20.2. So thank you, Nikki, for doing this for us. It's really a great project, and I'm going to show a demonstration, just a little background, the device list. So if you are entering a valve case and the patient had a valve implanted, newer devices that became available after the data specs for version 4.20.2 went to the vendors. If those devices were FDA approved, or perhaps they were still in development and now are going through for approval, they were not available for us to include on the device list that was sent to the vendors when the data specifications were built. There's a list of devices right now. I think it's around 12 or 15 devices that have since been approved or are now undergoing approval through the FDA that we need to include within our data collection for the aortic, mitral, tricuspid, and pulmonic spaces. So because those devices are not able for you to select on those drop-down menus, and I'm going to talk a little bit more about the vendors. This is not a vendor issue. This is just a common database issue. Because those devices are not available on the drop-down menus when you go to enter an implanted device, you have to choose FDA other or other FDA approved or other non-FDA approved device, and then just enter in the size. It's not quite ideal because we really need to be tracking these devices, especially those that came out right after these data specs went to the vendors in early 2020. So we came up with a solution. It's a pretty straightforward, not too much extra work, I hope, to enter these devices that are currently not available. There will be a link, this red cap link, and you can also do the QR code here on the screen. We'll be sending out notifications to sites via the STS database news, a standalone email. It will be in the training manual, and this link will be available underneath the additional resources on version 4.2.2. We're asking that you start with July 1st, 2022 cases. However, you may go back and enter previous cases, but it's not required. Double check the specs before entering a device using this method, just to make sure that it really is not on the device list. The way I check this is I go into the, let me pull this over here. I go into the data specifications, and I'll just give you one device on the Sapien. Is one that's common that I have gotten asked for. I go into the data specifications for the version, and if I do have my control off and I want to see if the Sapien valve is in the list or not, it's going to be listed a few times. I can see that here's the Sapien valve. This is a model number that starts with 9,000. There's a couple models. I think we're on Sapien 3 now. This is a 9300 Sapien valve, 9300 TFX. So you'll see the model number here. These two number signs usually mean that there's a size that's associated with this model number. So say if this is 26, 9300 TFX 26, that would be, you would just type in this 9300 TFX and it will pull up the Edwards Sapien transcatheter heart valve. You enter the size in the next field that's available on the data collection form. Now, if for some reason we did not have Sapien on this list when you went to go enter it, and I'll give you a valve that I think the Inspiris is one that we do not have. There's another, what's the valve, Melinda? Hold on.
It's the Inspiris 1060 or something that we don't have. Or it's the one with the 60 in it. We have the one with the 50, but not the 60.
Thank you. Yeah, it's 11600A, correct? That we don't have on the list.
Yeah.
So there's two Edwards Inspiris valves. This 11500A was approved and it was added on the list ahead of version 4.20 going live, and it was able to be sent to the vendors to be included in that drop down. The next valve the other valve that got approved that is also an Edwards Inspiris is 11600. You will not find that valve on the list. So just pay attention to the model number here, the beginning of the model number, and the valve name. If it's not on the list, then we're asking you to use this secondary method for capturing it. It's very simple, very straightforward. And what it is, this is the first screen. You enter in your participant ID, the patient ID, the record ID, and the surgery date. You would hit next. This screen pops up and it's just the device information. You select the anatomical location. Was it aortic, mitral, tricuspid, pulmonic, or other? I'm not sure what other is, but you never know if we're ever going to need other, so it's there. And this is what that looks like. And then once you select the position, I selected aortic valve. We have a list of valves that are not on the list, and these are ones that we know about. So, it's the Connect Resilia. So the 11060A Edwards Connect Resilia, I guess. I thought there was an Inspiris too. I guess I'm wrong. You just select the device name, and then you hit submit, and you get this message that says, "Thank you, your response has been saved." This is a link that I said, will be available. It's very easy to get to once you get here. I would just save it to, honestly, I would just save it to your desktop, whatever computer you're using to abstract data from, perhaps rename the icon to STS devices or something like that. So if you do come across a device that's not currently available in the list, after you double check it, to just enter it this way. And then we'll be able to track it better. The vendors have, a vendor has offered to add these devices into their software now. Unfortunately, because these devices were not part of the original spec update in early 2020, adding anything into the specifications on the vendor side changes the would change the version, would change the specifications. The lists have to match, and IQVIA has parameters in place for these implantable devices that if they receive a device that's not part of that list, it will reject the whole file. So we have to make sure that we adhere to version 4.20.2 rules. And so we are not able just to add these devices into the vendor software. And not only that, but we can't guarantee that we would get all of these extra devices added in, or that all the vendors would be able to update it, or that, in 3 months from now, when another device gets approved or is out for approval and we have to add it, we can't guarantee that all vendors would be able to keep maintaining this list in near real time as expected by STS. Going through this REDCap form means that STS is responsible for maintaining this other list. It's one place and we don't have version control issues. So we're asking you to do this starting with July 1st, 2022 cases. If you choose to go back, if your surgeon has been, say using the Edwards Resilia, the Connect, for quite some time now, and you want to go back and enter those cases in, feel free to do that, but it is not required. We're just asking with the July 1st cases. And then I just also wanted to show this. If there's a device that your surgeons are entering and you don't see it in the data specifications, the list that's with the vendors, and you don't see it on this list, when you do the device name, this drop down, you don't see that what you're trying to enter, you don't see it listed. Choose other and then put the name in here. We'll be able to track it and add it to the list. So the next time, hopefully the next time you go back, it will be listed here. And I see it looks like we have a spelling thing, but we'll get that fixed. So, so this is only for valves. And let me see if I have that slide there. So this is only for valves. It's for the aortic valve, the mitral valve, tricuspid and pulmonic valve, or the aortic valve composite grafts, which are those devices that you enter into the aortic valve implant section within the aorta section that likely the composite grafts are the valve, the root, and sometimes part of the ascending. So for the aorta devices, just specific aorta devices, not composite grafts, not the valve composite grafts, you still enter all of those within the aorta implant section. Again, there's no drop down. There should not be a drop down for those devices. You are free texting in the model numbers for those. So there's no reason to enter those devices within this list. This list is just for the 4 valve spaces and the aorta aortic valve with composite graft device. Okay. Melinda, hopefully I didn't take up too much time.
Well, looks like we have a lot of questions already, but I'll try to get through this, and I suspect we'll have a lot more. So, you guys have asked us to talk about insurance, so I'm going to try to talk about insurance. First thing I want to say is that I'm not an expert in insurance. Your hospital billing department will be your best friend. If you have questions and you're not sure about how things are recorded at your site, then that's who you really need to reach out to. So when we talk about the payer, we want to indicate the primary insurance payer at the time of arrival. Okay, so what they arrived with. And insurance is in the risk model, so it's important to fill it out. I've had sites I've seen before that just don't bother to even fill out insurance, but it is in the risk model. So you want to make sure that you do complete it, and it's what the patient arrives with at the time of arrival. So if you look in the chart and it says Medicaid pending, well, that means they didn't have insurance when they got there. So so that's how you want to code it. Not that they're going to get Medicaid, because that's not the insurance they had when they arrived at the hospital. Next slide. So we're going to talk about Medicare a little bit. And when we code Medicare, it includes the commercially managed options too. So we have traditional Medicare, which is this nice red, blue, and white card that most of you are probably familiar with looking at. That's your traditional Medicare. And then this also includes Medicare Advantage plans, which we'll talk about in the next slide. So first of all, let's just talk about traditional Medicare. So this is traditional Medicare. It's Medicare Part A. It could be Medicare Part B too. Most often you'll see the patient has A and B together, but sometimes they'll only have A. Sometimes. So just know that if you see this card, if this card's scanned in, this is traditional Medicare. Now you'll see over here this funky looking number. It's called a Medicare number. It's composed of letters and the alphabet and numbers, and this is your MBI number. Okay, so this is sequence 294. This used to be called, some people may still call this a HIC number. If you've been around, it used to be called a HIC number, and it basically was the patient's social security number with the letter A at the end of it. That changed due to privacy concerns to this sort of de-identified number, and now they call it an MBI number. So when you're talking about primary payer Medicare Part B, sequence 295, okay, so Part B is for a fee for service. That is only people who have traditional Medicare plans. Okay, so if your patient has a traditional Medicare plan, and on that plan they have Part B, that is Medicare fee for service. If your patient has a Medicare replacement or Advantage plan, or some sort of Medicare managed plan, okay, they do not have fee for service. They have what they call private fee for service. So for this particular sequence, 295, we're looking for traditional Medicare plan that has fee for service. That's what Part B is. Okay, next slide. So when we talk about Medicare C, which is basically your Medicare Advantage plans. Okay, so we're still going to code this as Medicare, because that field encompasses Medicare and commercially managed Medicare. But a Medicare Advantage plan is managed by an insurance company. Okay, so it's a Medicare program, but it's managed by an insurance company, and quite often they have additional benefits such as vision or dental and things like that. They also quite often require that the patient see providers in a network. All Medicare Advantage replacement or managed care plans are captured in the payer category as Medicare only. So if it's Medicare HMO, you code it as Medicare. It's Medicare Advantage, it's coded as Medicare. Medicare Part D is just a prescription drug coverage. It's optional, and it's only available through private insurance companies that contract with Medicare Advantage or managed plans. So when you're thinking about Medicare Advantage plans, there's HMOs, there's PPOs, there's private fee-for-service, there's special needs plans, and there's even medical savings account plans. So, but all of these plans, all these managed Medicare plans are coded as Medicare. They all go into that Medicare category. Next slide. So these are just some examples of what some cards might look like. So all of these patients, all of these examples here are Medicare Advantage. So you'll see up here, it says Medicare Plus Blue PPO. That's Medicare Advantage. We got Primera Blue Cross Medicare Advantage, HMO POS. That's a managed program. United Healthcare, Medicare Advantage PPO. Okay, that's another managed one. Down here we've got Anthem, Blue Cross, Medicare Advantage, HMO. So there's no HIC number or MBI number. See, I'm old, I still call it a HIC number, but it's really an MBI number in sequence 294 because these are all managed Medicare plans. And there's no fee for service because these are private for service plans, not fee for service plans. Okay, these are your Advantage plans. Next slide. Okay, so now we get into the whole different category, commercial insurance. So commercial insurance is health insurance provided and administered by a non-governmental entity. It covers medical expenses and disability income for insured. Okay, so commercial insurance also includes Medicare supplement plans, such as Medigap or AARP. So if you have a AARP supplement plan, that's managed by a commercial, that's commercial insurance. Medigap is another, it's a commercial insurance that is a supplement to your Medicare. It's a private insurance plan. It's not a part of Medicare. You will also see point of service plans, POS, and preferred provider organization, PPO plans, with commercial insurance too. So like if you look at these cards, so this is United Healthcare. It's a POS plan. You don't see anything about Medicare on here. This is just a regular commercial plan. This is your Blue Cross Blue Shield. It's a PPO plan. Again, there's nothing here about Medicare. It does say federal employee program, but that doesn't matter. This is a commercial plan that is for the federal employee program. Down below here, you see that this is HPHC Insurance Company. It specifically says Medicare supplement. Medicare is your primary bill. So basically, this is a supplement to a commercial supplement that pays for what Medicare doesn't pay for. Next slide. Okay, we'll talk briefly about Medicaid. So Medicaid in the United States is a federal and state program that will help pay for medical costs for persons with limited income. Medicaid also offers benefits not normally covered by Medicare, including nursing home and personal care. So all Medicaid whether it be commercial, managed plans, any kind of Medicaid is captured in the Medicaid category. So, for example, if you have, this is the Georgia, state of Georgia Medicaid, that's Medicaid, going to be captured as Medicaid. We've got Anthem, Blue Cross here, but it says Medicaid for Kentucky Health, that's Medicaid. We have another one over here that's Health Plan of Nevada, Medicaid. So all of these, whether they're managed or administrated by commercial insurance, they're all captured as Medicaid. All right, so we're just going to briefly look at a few other ones. So again, we've got examples of some commercial plans here. You've got United Healthcare. You don't see, it's a Choice Plus plan. You don't see anything about Medicare here. Got a nice group number. That's a commercial plan. You got a Medicare supplement plan down here. It clearly says AARP, Medicare supplement plan, and you can see that United Healthcare administrates this. These are commercial plans. As opposed to over here on the other side, you've got an ARP, Medicare Complete. So this is an ARP Medicare Complete plan. It's an HMO. So this is a Medicare Advantage program. So this would be coded as Medicare, because all Medicare plans, either traditional or managed, are coded as Medicare. Even the HMO Medicare plans are coded as Medicare. Next. All right, we'll talk a little bit about HMOs. So HMO gives you access to certain doctors and hospitals within a network. So it's kind of it's sort of like PPOs, but not exactly. Care under an HMO plan is covered only if you see a provider in their particular network. Then you really don't have opportunities to get outside of the network. It's typically has more restrictions. So we've already discussed about Medicare HMO. So you can see here that this Horizon Medicare Blue Advantage HMO, we know that this is a Medicare Advantage program. Even though it says HMO, we're going to code that as Medicare. As opposed to the other Blue Cross Blue Shield of Arizona over here, this is a statewide HMO network. It's got a member number. It doesn't talk anything about Medicare at all, but it tells you it's an HMO insurance. So this one would be coded as HMO in the HMO field because it's strictly an HMO insurance plan. And I think the reason there's a separation between commercial and HMO is because of the restrictions for HMO. So if it's because you think about it, this HMO really it's administered by a commercial plan. It is Blue Cross, but it's an HMO plan. So we want to be able to identify patients who are in these HMO networks, commercial networks, I should say, into a separate category, because I think sometimes the care might be a bit different than the care that you get in just a commercial plan because of the restrictions and that are in an HMO plan. So that's kind of why it's a separate field, just so you can understand that a little better. Okay, next slide. All right, I'm going to go through these really quick because we don't see these that often, but U.S. military is pretty easy to identify. It's the VA or TRICARE. Used to be called Champus, right? But now it's called TRICARE. So those are typically your military insurances. If you have a non-U.S. insurance plan, that means that it's insurance from someplace else. So you can see we've got an Ontario insurance plan. We've got a European health insurance card. So these are non-U.S. sources that are providing their insurance. We also have an other category, which is like Indian health, correctional facilities, state-specific plans, other government plans, or charitable foundation funding, because I know you probably see a lot of that in charts. I do. And then we have the non-self category. Now, the only caveat to this is if you see Christian healthcare ministries and Medishare Christian Health, we are going to be coding that as in the non-self category per surgeon leadership. That's where it was decided to put that. So I think the next slide, I think, is we're going to go into some scenarios, right, Carol?
Yep.
Yeah. So we're going to do a couple scenarios, and I know that was quick. I'm hoping that the scenarios will kind of help solidify what I just went over. So first question, if Medicare A and B and ARP Medicare supplement is listed for insurance, how do I code this? So do I code as primary payer as Medicare and secondary payer as commercial? Code primary payer as commercial and secondary payer as Medicare, or I haven't a clue. So how are you going to code that? Can't see the poll.
You can't see it. It's running, I promise. I have to figure out why. Once it ends, hopefully I'll be able to figure it out for the next one. They're still coming in. Melinda should have to tell us a joke as the polls are running.
A joke? Let's see. Oh, here's a joke. It's 46 degrees at my house yesterday. Everybody else is burning up.
That's a joke. That's funny. Okay. That's good. I'm going to add
That's
the
not really a
poll.
joke.
Here are the results.
Okay, it looks like 96% of the people got that answer correct. So yes, this is Medicare is your primary, and your AARP Medicare supplement is coded as your secondary, and that's commercial. Thank you very much. Okay, let's go to the next slide.
I'm a little concerned 10 people got it wrong though. Medicare A and B. So the patient they come on they have two cards. They have a Medicare card and they have an ARP, and it says Medicare supplement, or it says ARP, just an ARP card. The Medicare card is going to be the primary. So if you have questions on that, any of our 10 people, please let us know.
Well, Medicare always pays first. Okay.
No, it doesn't. It doesn't always pay first. It pays first as long as the patient is not working. But you could, if the patient has Medicare, but they're still working and they have a commercial insurance, the commercial insurance pays first and then Medicare pays second. So you have to depend on your admitting to make sure that they put down the primary and secondary insurance correctly.
That's true. That's why I said billing is your best. Billing is your best friend with this stuff, because it's very complicated.
It's tricky. It's tricky. Okay, stop sharing. All right, next slide. Oh,
there we go. All right, can we move on to the next one?
Yes, ma'am.
Question number 2. Patient has a Humana HMO, Medicare. So it's a Medicare HMO. Do I code this as Medicare or commercial or HMO? So you code as Medicare and commercial. B, code as Medicare. C, code as Medicare and HMO. Or D, help me.
And Melinda, sorry I didn't see that on your slide when I reviewed them.
It's all right.
Okay, so the patient has HMO Medicare. So that means they have one of those HMO cards that has Humana on it, but it also says Medicare plan. So one insurance. Okay, good talking points coming up. There you go.
Okay, so 63% of the people said it was Medicare, and that is the answer. Haha, the 2%, like, help me. Okay, so all traditional Medicare, Medicare Advantage, managed plans, HMO Medicares, they're all captured in the primary category as Medicare only. There's no secondary payer in this scenario. If that's the only thing that's listed, is that the patient has a Medicare HMO plan.
So for this one, they might have gotten confused by this right here. So Medicare, so the options were Medicare and commercial, right?
Mhm. Or
Medicare.
Medicare and HMO.
Or Medicare and HMO. But I bet people coded it said Medicare and commercial because of this right here, because it would be Medicare and then a medically commercially managed Medicare plan.
It is true.
Yeah, that okay. Maybe they know more. Maybe they okay. Thank you.
Yeah, I probably didn't put the sequence numbers here, so that's could have confused some people.
That's okay. We get through it.
It's hard to get through insurance.
It is hard. Insurance is hard. That's why people like are masters at your hospital. They're so valuable who understand the insurance plans.
All right. For a patient who has Medicare managed insurance, there is a policy number, and this is what it looks like: 790111118. Is this the MBI number? So A, no, this is not the MBI number. B, yes, this is the MBI number. And C, what is an MBI number?
Oh, and oh,
So this is Medicare managed insurance or replacement or advantage. Okay. And that number is just a straightforward 7910001. So is this the MBI number?
okay. People are voting fast. I think they like your polling questions, Melinda.
I wished I could see the poll. I can't see him.
Did you see the last one?
No. How did they score on this question here?
It's still coming. Hold on one second.
I saw the last one. Once it's done, I can see it, but I can't see it while it's going. Okay. All right. 89%. No, this is not the MBI number. And that is the answer. So let's go over that. So an MBI number is not the same as a member policy number. And here's the key. An MBI number is only associated with traditional Medicare. Traditional Medicare, that red, white, and blue card. Okay. And an MBI number is made up of numbers and letters, and it's about 12 characters in length. I think it was like, I don't remember what slide it was, probably like 25 or 24. Yeah, there it is. That's your traditional Medicare number. That's your MBI number. And you can see that it's made up of numbers and letters, and it's only for traditional Medicare.
Do they have
Hmm?
do they have an MBI number if they have a commercially managed plan?
No,
Okay.
not in the sense that we're looking for it. Do you know what I mean?
Okay.
Because a commercially managed plan is going to have what they call a policy number.
So then this explains the if no for a commercially managed Medicare plan, then do you know the MBI number or HIC number?
Right. That explains why. Because see, yeah.
Okay. Look at we're making all kinds of connections for you today. Let's see.
Right.
Slide. I think we're on question 4.
I think. Okay.
Okay.
So I have a patient who has Aetna Medicare PPO. Okay, so that's a clue. This is a Medicare PPO, which is a managed plan. I've answered yes to Medicare and yes to commercially managed Medicare plan. How do I answer the question primary Medicare payer Part B? So yes to primary payer Medicare Part B, no to primary payer Medicare Part B, or send a question to the FAQ mailbox. So we got a PPO plan, which is managed Medicare. We know it's commercially managed. So how do I answer that Part B question, which is fee for service?
Can you see the question now?
I can't see the polling.
Can you see that if you can vote on it?
Yeah, I saw the question. Yeah,
Okay. But
it doesn't matter. I'll be surprised.
Oh, I know why. Hold on. How about now?
Oh, I can see it now. Ooh,
Sorry. Like, well, I knew there's a
there
way.
we go.
Sorry.
All right.
Everybody else can be surprised. Okay. All right, I'm going to end it here.
Okay, so 84% said no, this is not primary payer Medicaid Part B. And that is the correct answer. So again, let's just review. Only traditional Medicare, that red, white, blue card, has fee for service. So Medicare Part B is what we call fee for service. And that's what we're getting at in this question. Do they have Medicare Part B? If you have a managed plan or an advantage plan, they're going to pay via PFFS, which is a private fee for service. That's not Medicare fee for service. So the key here is, if you have to have a traditional Medicare plan to have Medicare Part B, basically. That's the key. If you've got a Medicare Advantage plan, you're not going to have fee for service.
Okay, thank you.
Okay, question 5. I have a question about coding a primary payer for a patient who presents to the hospital with no insurance with Medicaid pending. I already gave y'all this one, I think.
Oh, this is a good one. This is a good one, Melinda.
They already answered it. Are these patients coded as non-self as primary insurance with Medicaid as secondary, or are they coded as Medicaid primary? So we code as
That's a
Medicaid.
good question. Tricky, Melinda.
Code as primary payer is none, and secondary payer Medicaid. Code as none. Call a friend.
They're not calling. Nobody's calling you. Not on this one. We tried to answer as many questions as possible in the chat box, or in the Q&A. So hopefully, we won't be over too far.
Okay. Well, 92% of you said none, and that is the correct answer, because remember that you're going to indicate the primary insurance payer at the time of arrival. So at the time of arrival, this patient didn't have any insurance because they got Medicaid pending, meaning they've just applied for it. Okay. So, and the reason we want the insurance at the time of the arrival is because it's in the risk model. And of course, people who aren't insured will have a higher coefficient in the risk model than those that have insurance.
That's right.
Okay. Is that the last question, or do we have one more?
One more.
One more. Okay. Blue Cross Federal Plan with commercial provider paid by Blue Cross Blue Shield, code as other or commercial or what?
Okay.
So,
Blue Cross. Oh, let me launch the poll. Blue Cross Federal with commercial provider. So the Blue Cross Federal plan, that's the commercial provider. How do we code this?
Yeah, so it's a Blue Cross Blue Shield federal plan, and they want to know, do we code this as other or commercial or what? How do we code this?
Okay, let's see what happens. I think you did a good job educating today.
Insurance is tricky.
It is tricky. And there's so many little there's so many possible combinations of things.
Yeah, this is just the bare basics to with some tips and hints about certain few things.
Yeah.
Again, your billing department is probably your best friend when it comes to this. All right, so 91% of you guys said commercial, and that is the correct answer. This is a commercial insurance for federal workers, basically. So it's a commercially provided insurance for federal workers. Sometimes the Blue Cross Federal plan throws people off because they think it's some other type of government insurance, but it's really just a commercial.
Yeah,
insurance.
Blue Cross. And there's a question in here from Danette. It says, how do you know the Blue Cross Federal had a commercial provider? Blue Cross is a commercial provider.
Right.
Blue Cross Blue Shield
Right.
is the commercial provider for that. Good job, Melinda.
Thank you.
And we're going to do Q&A, and I'm going to go back. Somebody asked to see the date slides. I'm going to pull that up. All right, let's go through these. You're welcome, Danette. Patient has managed Medicare Aetna. This will be primary Medicare, Medicare Advantage. Patient also has Medicare IME. This would be Medicare secondary, question mark.
I'm sorry, I don't see the question. Where are you reading from?
It's the last one, the
The
very
last
last
one. I'm like, there's so many. I had gone to
I
the
did-
top.
I didn't want to get off the, I didn't want to get off the
Okay.
insurance
Patient
questions.
has managed Medicare, so it's Aetna. This will be primary Medicare. Correct. A Medicare commercial managed plan. Patient also has Medicare IME.
I don't know
I
what
don't know what,
IME
I don't
is.
know what Medicare IME is. I have no clue.
Maybe if you have a picture, send it in to us.
Or, ask your billing department. This may be, I don't know what IME is. I've never heard of it. Okay.
How do they figure out insurance? Our hospital does not have a snapshot of the insurance on arrival. Our insurance is kept up to date via face sheet. How can I figure out insurance on arrival?
Well, generally speaking, and check with your billing department, but the insurance that's on the face sheet is going to be the insurance that they arrived with. Or the insurance of record for this particular patient. If you see something that says Medicaid pending, you know that they had just applied for that.
Mhm. Yeah, I agree. The other thing I would say is that they should be able to provide you with a log of change, if things changed for your insurance. And they just updated the face sheet. But you should be able to pull a face sheet down from a specific time. I would check within your hospital how to do that.
Yeah.
Let your IT folks know what you need to do, and I bet you they are able to tell you how best to do that so you get the correct time for that field. Okay, I'm going to go back up to the top for questions. Sorry.
Okay, we're going back to the top now.
Back to the top, yeah. When I print the risk report, the font, and I'm just going to stay on for a few more minutes to see what we can get through. When I print the risk report, the font size is so small it's hard to read. When will we be able to make format changes? This is for IQVIA if you're listening. There's Melanie.
Hi, Carol. Yep, I'm here.
Hi.
We'll have to discuss that further. We didn't have any changes at the moment in regards to the font for the ACSD risk adjusted report.
Okay. Maybe they should submit it as a.
Yeah, definitely submit it to support as an enhancement request, and we can go ahead and review that.
Thank you. Thanks, Melanie. And then Nikki Parsons, if you're there, this question is for you. And thank you for joining us. Will we be able to query our cases entered in REDCap?
Yeah, I believe so. We would be able to connect this to our normal database. If this is something surfaced by IQVIA, I'm not sure if this is related to that. So, do you know, Carol?
I think they're looking for maybe can they see the number of times where they entered a specific valve?
Yeah, we can talk to her and see if we can provide that eventually. But it would have
that
to
would
be
require some type of login though, and
yeah, but it's certainly possible. We'll collect the data and then eventually we can give them access to something like that.
Okay, all right, thank you. Thanks, Nikki.
Yeah.
Are there any consequences, Melinda? Are there any consequences for not entering a patient's MBI number?
No.
No
Not that I'm aware of.
consequences, but I do ask that you enter it in because this is one of our the linkage factors that we use for connecting when they do long-term longitudinal reviews of patients' data. This is one of those numbers that we can use to link cases with outcomes. How do you capture Optum VA insurance, military or commercial private? They are a sub of United Health and cover VA patients, community VA health.
Well, my first question is that does the VA mean Veterans Administration or does it mean something else? I mean, because TRICARE does contract with a lot of commercial carriers to provide military insurance through TRICARE. So that would be my first question, Donna, is to find out if this is insurance that is being provided for the Veterans Administration or through TRICARE. And if it is one of the commercial plans, then you'd want to code that as military.
Okay, thanks,
That
Melinda.
works with TRICARE. Yeah.
This Hannah had a question. She said that the patient had an HSA, a healthcare spending account, and I said that the healthcare spending account is not insurance. It's a spending account. We don't treat it as insurance. And then she said she showed a card with this and said it was commercial. And Hannah, by your response, are you saying that the patient said it was commercial or the card said it was commercial? HSAs are usually not any type of commercial insurance. So just clarify that for me, please. What if a patient has Medicare Advantage plan as well as Medicaid? Wouldn't Medicaid be the secondary and not commercial?
Well, yeah. I mean, you've got Medicare and then you have Medicaid. So you'd want to code both of those.
Yeah, you would code Medicare, commercially managed Medicare plan. And then for the secondary payer, you would code Medicaid.
Right.
Okay. Some of our correctional patients have a Medicaid correctional plan. Is that still coded as other?
I think if it's Medicaid, you should code it as Medicaid, but that's just me. What do you think, Carol?
No, I agree. It's Medicaid. It should be coded as Medicaid. Primary payer is Medicare and box on commercially managed, and still to code for secondary for commercial. No, you would code this patient who has a Medicare Advantage. You are going to code Medicare, commercially managed Medicare plan. If that's the only insurance they have, then you code none for secondary.
Yeah.
We tried that, set up a new account, all the questions still enabled. Okay. There's an email. I think that you can, Jill, there's an email on that link you can access, or send me an email and I'll forward you over to the right. Oopsie, sorry for this scrolling, everybody. I'll forward you over to the right spot. Hold on. When primary is Medicaid, do we still choose non-self for secondary, even though patient would be paying?
Yes.
Thank you.
Because none is one of the options.
Yeah, it's non-self-pay, so you would code that. Non-self is the second for secondary. I see the MBI number all the time for our Medicare Advantage patients. Our billing office always includes it. I don't think they have an MBI number because they forego that when they choose Medicare Part C.
Yeah, I think what you're seeing, Pamela, is the breakdown of the Medicare Advantage plan. Because I've seen that before too. You can clarify that with your billing department, but traditional Medicare plans have an MBI number. Medicare Advantage plans will not have a primary MBI number if you were to look at their card.
Yeah, I think another way to look at it too is the MBI number is the Medicare beneficiary ID, and the patients who choose to have the Medicare Part C are foregoing their beneficiary, the benefits of Medicare. So they're foregoing that. They're giving that up to choose Medicare Part C, which is requires, that the commercially available plans provide services that meet the requirements of Medicare, but they're not billed through Medicare. If the Medicare is a red, white, blue card, do you mark Medicare sequence 292? Medicare. Okay. sequence 292 as no, and then go to sequence 295 Part B section and mark it appropriately. That's
No,
correct.
no. So you got traditional Medicare, so 292.
Yeah, I think that's right.
Is it right?
Medicare, you mark
Oh
292.
yeah, 292 is no. Yes, I thought they were talking. Never
Yeah,
mind.
the Medicare got Medicare word. So Medicare, so yeah, no to commercially managed plan, and then yes to primary payer or fee for service, which is Part B.
Right.
Okay. If Part B is only applicable to traditional Medicare, why do you have to answer it for commercially managed Medicare plans? Yeah, I think that we meant to make this no. I think this should have been a child of commercially managed Medicare plans equal to um
To know.
no yeah to no, right. It should have
Mhm.
all been under the same. That's a good pickup, Elizabeth. Does age give us a clue? For example, 50 years old having Medicare as his insurance. Do we code this as commercially managed, or do we say no to commercially managed?
Well, first of all, age doesn't really give you a clue. I've discovered that because I see lots of people on Medicare for different reasons and they may be young. Do we code as commercially managed or no to commercially managed? It depends on what type of Medicare it is. I mean, if it's just Medicare AB, and that's all that's documented, I would code that as just traditional Medicare, not commercially managed.
Okay. I do not see the letter. Maybe I'm missing it or it's not posted yet. I don't think it's posted yet, Elizabeth, but if you want to reach out to Emily Conrad, we can certainly do that and she'll send it to you once it is posted. Her email, I'll put it in the chat box, is in the chat box for you. Oopsie. Next, where can we find who our main contact is for audit? So it will be your primary data contact and your surgeon representative. If you have a question about who your primary data contact is, please email this stsdb@sts.org and they'll be able to help you with that information. Now, when we have a data release agreement for payers or centers of excellence and there has been an IQVIA error, is new corrected data sent to the contracted party? So Karen, you're asking, were corrected reports sent out for the Anthem? And yes, corrected reports were sent out. Is the presentation, in the presentation, Melinda said it was a commercial for HSA?
HSA, I don't believe I said that, but we could look maybe
Let's see.
in one of the pictures, I guess. Let's see. It's Medicaid. It's a POS, PPO. Here's a Medicaid supplement.
What's it there?
I don't know. I don't see any HSAs, Hannah.
No, I don't either.
Okay.
Yeah, I don't see any. Maybe we're missing it. That is what I've been doing. Thanks. You're welcome. In the risk adjusted all procedures report, where can I find the total count of like group? I'll have to pull it up, Julia. I'm not sure. If you want to send that email to me, I'll be happy to look into it and look and see where that's at. What about UHC, a dual? It's a plan for Medicare and Medicaid all in one.
I don't think we can select more than one primary payer, can we?
No. It's a state insurance though, isn't it?
I have no idea. UHC duo, I don't know what it is.
Yeah. I would send that in as a question with a picture of the card.
Yeah, because it's kind of interesting. Or talk to your billing person, because
Oh yeah, that's right. Talk to the billing
a
person.
lot of times that's what I suggest. People send me questions when I've never heard of stuff. I'm like, you really need to become friends with your billing department.
Yeah. The red cap link, the more information will be sent on that. We don't need to access it now. It is live, but this is the red cap link. We'll send more information in an email and database news and post it on the website and in the training manual. I believe IME has something to do with hospital adjusted cost for teaching hospitals ratio to residents. They have way above my head to give you all a good
Oh,
explanation.
yeah. There is something like that. There's a designation. Maybe that's what it is, IME. There's a designation for teaching hospitals. You get a little extra money, I think so,
Oh,
with your Medicare. So it'd still be Medicare.
okay. I know I said the agenda for EQ is being worked on. Will adult session be 8 to 5 p.m.? It'll be something close to that, Amy. Thanks for reviewing. Always confusing and helpful. No, Medicare Part B is not just outpatient services. It's actually the, well, I guess Part A is in hospital only. Part B covers the outpatient
service.
part. Yeah. Here, I like to Google. Let's see if we can find something here.
Fee for service is usually provider cares. Provided.
Doctor
Doctor, yeah.
services. So that would be so inpatient, the doctor services probably related to that, and then other medical services. Part A doesn't cover, also preventative care. And then I'm very confused about saying that Part B is for inpatient Medicare FFS. FFS. So it probably covers, let's go to Medicare and see what Medicare has to say.
Services from doctors and other healthcare providers. So it pays the providers. It's who
Yeah.
pays your doctors and your anesthesiologist and stuff like that.
It doesn't just cover the care received in the hospital. And my care received in the hospital, whatever the hospital charges, right? You get different bills from your doctors, from your surgeons, whomever, like Melinda just said.
Right. So the Part A covers your hospital costs, but it does not cover your fee for your providers. Okay. So like when the anesthesiologist bills you for doing that surgery, or the surgeon bills you, or whatever. Part B covers that.
Thank you. And then insurance is required for the risk model starting with version 2.9, and that was with the new model update in 2017, 2018. Thank you, Pamela. Yes, it is state. IT was called Ascend HSA. I would have to check you, Hannah, I would check with your billing department on that. I do not believe that is a commercial insurance plan. It's a health savings account.
That's what it
Your
looks
savings
like.
account. So copay the same as fee for service.
I have no idea what that question is. Is copay the same as fee for service?
Yeah, fee for service means that you're paying a fee and you're receiving something back. So you're paying the doctor, you're receiving care from the doctor, that's the service, and you're paying the doctor. If there's a copay or not a copay, that's all part of the different insurance plans. It has nothing to do with the fee for service. Okay, you're welcome, Lucretia. So the IME would be traditional as there's an MBI available.
I would think so. I would think if it's listed as just Medicare A and B, the IME is just an extension saying, hey, you're gonna get a little bit more money because you got residents working here. It's not really like a separate insurance plan. It's like saying, hey, we're going to give you a little bit more money because you have residents working here at this hospital.
Right. Okay. I think we're going to, thank you, Melinda. Great presentation. Thank you, Nikki from STS, from joining, our IQVIA friends and all of my STS coworkers. We're going to end it now. So great presentation, Melinda, as always. And Julia, you had 2 questions in the Q&A that I didn't get to, but if you could please email me and send me screenshots of questions, I'll be able to respond better to you and give you hopefully the right answer. Okay. All right. Thanks, everybody.
Carol.
Yeah,
Nice job,
thanks.
guys. Awesome.
Thank you. I hope you all have a great rest of the day. And if you're hot, stay cool. If you're cool, if you're cold, get hot.
All right. Bye.
Bye, everybody.
Bye, guys.
Bye.